ठीक है, QR कोड आ रहा है ना तेरे, उससे देख QR कोड से।
Good evening, everyone. Respected Dr. Sadish Alvander, sir, esteemed members of IADP, and dear doctors. We warmly welcome you all back to another episode of Learn from the Master series organized by IADPE. Crossing 100 webinars has truly been an amazing journey, and we sincerely thank all the doctors who continue to support and attend our webinars, workshops, and engage with us through our Instagram and Facebook platforms. We are truly humbled by the wonderful response and positive feedback we receive from all of you. For those who are joining us for the first time today, let me give a brief introduction of IADPE. The International Association for Dental Practice Excellence is a dental educational platform that believes quality education and continuous learning are essential for achieving predictable clinical outcomes. Dentistry is continuously evolving, and through our webinars, workshops, and clinical programs, we aim to enhance the knowledge, skill, and confidence of dental professionals across different disciplines. So, without further ado, let us begin today's episode of Learn from the Master series. Today, we have a very interesting and clinically relevant topic: no more crowns, the new clinical standard in restoring endodontically treated teeth. And we are extremely privileged to have with us Dr. Sadish Alvanta, MDS prosthodontist and implantologist, to take us through this fascinating topic. Dr. Dr. Sadish Alvanta is an accomplished prosthodontist and implantologist with over 2 decades of clinical and academic experience, with a special focus on restorative and implant dentistry. He has extensive experience in prosthodontics, implantology, and restorative dentistry, along with a strong academic background. He has also gained valuable international clinical experience as a consultant prosthodontist and implantologist in Abu Dhabi. Currently based in Chennai, Dr. Alvanta is actively involved in private clinical practice and is also widely appreciated for sharing his clinical knowledge and simplifying complex concepts of dental professionals. With his extensive clinical experience and expertise in restorative and implant dentistry, we are truly fortunate to have him with us today. So, without taking many more time, I would like to invite Dr. Sadish Alvanda sir to take over the session and share his valuable knowledge and clinical expertise with us. Over to you, sir. Welcome.
Thank you, Dr. Joanne. First, let me just make sure that everyone is able to hear me. Dr. Joanne, can you confirm?
Yes.
Are you able to hear me? Okay, fine. So thank you, Dr. Joanne. I would like to thank IADPE and Dr. Shanu for giving me an opportunity to share about a topic that is really close to my heart. This has been my pet project for the past 5 years, and I'm really privileged to be able to share it on this large platform. Just to start off, let me not take too much of time giving myself introduction. I'm Dr. Satish Alavandar. Just give me a minute. Yes, I completed my undergraduation from Tamil Nadu Government Dental College in the year 2000. I then went on to do my post-graduation in Rajamutaya Dental College and Hospital in Chidambaram. This particular college is now called Kadalur Government Dental College. I then continued to work in the same college as a teaching staff for another 7 years. After finishing my tenure in Rajamuthiya Dental College, I wrote an exam to get accredited in Abu Dhabi and worked in Al Ahlia Hospital in Abu Dhabi for about 2.5 years. I came back to India in the year 2017, and after testing the waters for various opportunities, I decided to start my own practice in 2018. And since 2018, I am a full-time practitioner taking care of my clinic in Chennai. So this is just a short introduction to myself. Now about the topic that we are discussing today. What are partial coverage restorations? Okay. It is important to first understand what partial coverage restorations are before we even, step into why they are needed and other questions. So any restoration or any indirect restoration that does not require the preparation of a tooth, that is 360-degree preparation of the tooth, and which is bonded to the surface of the tooth and not retained to the surface of the tooth, is called a partial coverage restoration. This is a simple description. This is not a definition. So basically any restoration which requires only partial preparation of the tooth. It does not require the tooth to be prepared, all surfaces of the tooth to be prepared. Now, why partial coverage? Okay, so this is a question that I asked myself several years ago, and I hope that you, at the end of this presentation, you ask yourself when you go back to your clinic. So the first question is, what is the most common procedure that is done in any clinic? I would be logical in assuming that the most common procedure in any clinic would be a root canal treatment. After a root canal treatment is done, most of us emphasize to the patient that the tooth has to be restored with some sort of a restoration. Okay, and in most cases, it is a full coverage crown, either made up of PFM or zirconia or some sort of material like that. Now, the question that I asked myself was, according to published literature, what is the most common mode of failure of endodontically treated teeth which have been restored with a full coverage crown? Before I asked myself this question, my assumption was the most common mode of failure would be endodontic failure or crown dislodgement or some such common mode of failure. I was quite surprised to find out that the most common mode of failure of an endodontically treated teeth which has been restored with a full coverage crown is crown fracture, and more often than not, horizontal crown fracture. Now, how common is this? That was another surprise. It was ranging from 7% to as high as 59.4%. This is not a number that I'm just pulling out of the sky. This is based on literature. There was one particular article that was published in 1999 in the Journal of Endodontics, which did a observational study in a very busy practice. And they came up with this number of 59.4% of endodontically treated teeth restored with a full coverage crown undergoing horizontal crown fracture. Now, if almost 60% of the teeth that we are restoring after endo are going to fail by crown fracture, then we need an alternative. Now, before we go into the alternative and all those things, we need to understand why there is this increased risk of crown fracture when endodontically treated teeth is restored with a full coverage crown. For that, we need to understand a concept called the compression dome concept. Okay, in a natural tooth, enamel is designed to act as a compression dome. Inside enamel, there are certain microanatomical structures such as the peripheral rim of enamel, the subocclusal oblique ridge, transverse oblique ridge, and the maxillary web of enamel. These structures, along with the dentinoenamel junction, act by transmitting, transforming transverse forces. In other words, tensile forces into compressive forces, and then transmitting these forces towards the dentin. Dentin, being a resilient structure, is able to withstand compressive forces. So these forces are dissipated within dentin. So in a tooth, where this compression dome of enamel is intact. When the tooth is subjected to some sort of transverse force, the tooth will tip about an axis. However, when this compression dome is interfered with, okay, either due to an access cavity preparation or due to a crown preparation, this compression dome is lost and the tooth starts flexing instead of tipping about its axis. So what does this flexure cause? This flexure cause propagation of cracks within the tooth and eventual tooth fracture. There are two articles which are published in the one in the Journal of Operative Dentistry in 1981, which has shown that even a isthmus or a cavity preparation of about 1.5 millimeters width will cause a reduction in fracture resistance of a tooth by 40%. If the same isthmus is about 2 millimeters in width, then the fracture resistance is further reduced by almost 60%. There was another article published in the Journal of Restorative Periodontics and Restorative Dentistry in 2009, in which it was shown that a tooth that has a cavity preparation with a non-bonded restoration will flex more than a tooth which has been restored with a bonded restoration. Okay. Now, how do we actually transfer all these data to our everyday practice? So what is a typical endodontically treated teeth in our everyday practice? You have a large carious lesion. This large carious lesion is then excavated to create a large access cavity preparation. We then finish our endodontic treatment, and this large carious access cavity is then restored with a non-bonded restoration, something like GAC or amalgam, or in some worst cases, even with just zinc oxide eugenol. Okay. Now you have a isthmus or a cavity which has been filled with a non-bonded restoration. The tooth is already in a state of flexure. Now, what we do next is even worse. We completely remove all the enamel. That is, the entire compression dome surrounding the tooth is removed, and we cover the tooth with a cemented crown, a PFM crown or a zirconia crown, right? So what happens is that you have three distinct layers. You have a crown, you have a tooth that has been over prepped, and this over prepped tooth has a channel in the middle which is making it flex. So what happens? You have a strong zirconia crown. The zirconia crown is going to withstand all the force that is going to be subjected to, right? But the same force is now being transferred down to a tooth that is biomechanically not in a state where it can withstand those forces, right? So what is the alternative? Alternative is to go for partial coverage. Now, the minute I show someone a restoration like this, I'm most frequently asked two questions. So let me answer these two questions before we move any further into this lecture. The first question is, what if it gets dislodged? What if it gets debonded? To actually answer this question, my answer would be to say you need to believe in the bond. Okay. For this, I am referring you to two more articles. One article published in the American Journal of Dentistry in 2000. This article observed that natural enamel was bonded to natural dentin at a bond strength of 50 megapascals. This was the first finding. The second article, which was published in 2003 in the Journal of Operative Dentistry, found that when you used certain gold standard bonding agents following certain protocols, it was found that you could get a bond strength of equal bond strength of almost the same 50 megapascals that the previous study said. That is, just to explain further, natural enamel is bonded to natural dentin at a bond strength of 50 megapascals. So when you are bonding a restorative to a tooth, if you follow certain protocols and use a gold standard bonding agents, you can bond to dentin and I'm not meaning enamel, I'm saying dentin. You can bond to dentin. The indirect restoration can be bonded to dentin with the same bond strength at which natural enamel is bonded to natural dentin. Okay. This was mind blowing when I found this out. Okay. So this is the first thing you need to believe in. You need to believe in the bond. Second thing is, will the restoration be strong enough? Will it break? Will it fracture? Now let us look at what is the normal strength of normal enamel. Normal enamel is about 300 to 400 megapascals compressive strength. I think somebody is not muted. Okay, just to continue. Okay, so what is the compressive strength of enamel? It's about 300 to 450 megapascals. The compressive strength of zirconia that we use to restore most of our endodontically treated teeth is around 560 if it is 5Y zirconia, and it can go right up to 2500 megapascals if it is about full contour 3Y zirconia. We actually do not need that kind of strength. We need a material that is as close to the strength of enamel as possible. And in this case, in most cases, the gold standard restorative material for partial coverage restorations is lithium disilicate, which is around 400 to 550 megapascals in compressive strength. Lithium disilicate also has the added advantage that it can be bonded to the dentin, natural dentin of the tooth. We can also bond zirconia, but that is a can of worms that we can open on another day. Okay, so logically thinking, it would make logical sense to replace enamel with a material that has the similar properties to enamel, meaning it is a material that has similar compressive strength to enamel and it can be bonded to dentin. Okay, so lithium disilicate will suffice. It will not break. It will not get dislodged. So I hope I'm clear with this particular point. Oh, sorry. So having this in mind, I'm going to make three very provocative statements. Statement number 1, no endodontically treated teeth should ever be restored with a full coverage crown. Okay, I am not saying that full coverage crowns are bad or evil or anything like that. There are scenarios in which a full coverage crown will be justified. But in almost I would say 95% of the cases, endodontically treated teeth does not require a full coverage crown. What are the scenarios in which a full coverage crown will be justified? I will explain later. Okay. Second statement I want to make, and this requires a change in mindset. All of us are very defensive. We want to give the patient the strongest material or strongest restoration possible so that the patient doesn't come back to us tomorrow with a broken restoration, asking us to redo that restoration. Or else we want to give them a restoration with lifetime warranty so that when the patient comes back to us tomorrow, we are not footing the bill for the restoration again. But what sort of mindset we actually need to have is that the longevity of the endodontically treated tooth being restored is far more important than the longevity of the restoration that is being placed on the tooth. Okay, if the restoration fails, the tooth can be re-restored. But if the tooth fails, it is gone forever. Okay, the only other option we have is to remove the tooth and go for an implant. Okay, so we are trying to extend the life of the tooth. And the final statement is any form of tooth preparation that requires some form of retention form, grooves, slots, boxes, that is all kind of obsolete in modern dentistry. Modern dentistry depends upon bonding, getting a strong, predictable bond to the residual enamel and dentin should be our goal. not trying to make slots, grooves, trying to do crown lengthening to get as much, trying to engage as much tooth as possible. So there are some prerequisites. So this the biggest barrier that I come across when I start teaching or when I start talking about bonded restorations is that people don't want to do rubber dam isolation. Rubber dam isolation, when it comes to any form of bonding, is a non-negotiable. You will have to learn it. I say this to everybody. I learned rubber dam isolation when I was 45 years old, after 20 years of clinical practice. If I, at 45 years old, after having almost 20 years of clinical practice, am able to learn and inculcate rubber dam isolation into my practice, I believe anybody else should be able to do it. Second prerequisites. You're having an endodontic access cavity. This endodontic access cavity should be restored with a bonded composite restoration using materials, technique, and strategies that will reduce the stress caused by polymerization shrinkage on the walls of the residual tooth that is left behind. Okay, your polymerization shrinkage of the material itself should not cause micro cracks to form in the tooth. Okay, there are various techniques that can be followed, but because of the lack of time, I'm skipping that part. If anybody has any questions regarding this, you can ask me during the question session. And finally, this may sound like a very small part, but when you're doing your endodontic treatment or before your endodontic treatment, do not flatten the cusps of the teeth. This is usually done one to have length control, and other so that the patient doesn't complain of pain after the treatment is completed. There are other ways to accomplish these two goals. Okay, you do not need to flatten the cusps. Why I say you shouldn't flatten the cusps is because when you're preparing the tooth, your preparation has to be a morphologically guided preparation. So flattening the cusps will give you a preparation that is completely flat. You will not have any sort of passive positive seating of your restoration. Now, guidelines for preparation. Now, do all endodontically treated teeth need some sort of indirect restoration? No. This was an article published in, I think, 2023 by Cardoso et al. This gives guidelines on how to restore both endodontically treated teeth and vital teeth. Now, our field of interest is now only endodontically treated teeth. So, when it comes to endodontically treated teeth, if all the remaining walls have a thickness of more than 3 millimeters and all the marginal ridges and the oblique ridges are intact, then it is sufficient to give a bonded composite entrance filling and leave the tooth alone. Nothing will happen to the tooth. Now, however, if one of the marginal ridges are missing, the resistance to fracture of the tooth reduces significantly. In this case, we will have to give some sort of cuspal coverage. Even in this case, it is possible to retain some of the remaining marginal ridges, but still some amount of cuspal coverage is required. So basically, if the remaining walls are all 3 millimeters in thickness and marginal ridges are intact, you do not have to give an indirect restoration. If the marginal ridges are missing or if the remaining walls are less than 3 millimeters in thickness, then you will have to go for a full cuspal coverage restoration. Now, this is with regards to partial coverage. Now, when do we go for a full coverage crown? We go for a full coverage crown when less than 1/3 of the remaining tooth has, that is the periphery of the tooth, has walls that are less than 3 millimeters in height. We initially spoke about width of the tooth, but when in the remaining tooth, in the remaining residual tooth, if less than 1/3 of its peripheral walls have a height of less than 3 millimeters, then we'll have to go for a full coverage crown. And even in this scenario, we need to go for a bonded crown. Cemented crown will not stay on a tooth that has less than 3 millimeters of vertical height. Okay. So there are certain guidelines that we need to follow when we are preparing a endodontically treated tooth for a full cover, no, for a partial coverage restoration. The photograph that you see is a what we would call as a classical overlay preparation. Now I want you to look at the photo and just listen to what I'm saying. The first guideline is that the tooth prep should be in such a way that the ceramic restoration tooth prep should be in such a way that the resulting preparation has as simple geometry as possible. It should look almost flat. Okay. Second, you need to give enough space for your restorative material. In this case, this would be around 1.5 to 2 millimeters. Any sort of corners and sharp edges should be avoided. Anyone who's familiar with any operative dentistry textbook will come across this particular statement. Avoid sharp line angles and point angles, which will act as areas of stress concentration. So avoid any areas of sharp line angles or point angles. Okay. High tensile forces that any tooth will be subjected to should be transformed into compressive stresses by changing the prep design. How we do it? It is done by giving a 360-degree bevel around the tooth in enamel. Okay. The fifth point, any stress peaks or sudden changes in cross section, again similar to point number 3, any sudden changes in cross section should be avoided. All transitions, say for example, if you are breaking the contact with the adjacent tooth, you don't prepare a box. The box is blended with the occlusal preparation. Or everything should, all transitions should be completely smooth. There shouldn't be no sudden dips or valleys. Okay. Sixth point. Excuse me. Notch stresses should be minimized. Okay. Notch stresses are basically areas like retention grooves or seating grooves, which will create areas of stress concentration. So this preparation does not require any seating groove. All your retention is going to be through bonding. Okay. So no seating grooves are required. No retention grooves are required. Point number 7. The contact surface with the ceramic restoration should be made as large as possible. Okay. And finally, it is preferable if the entire tooth has a 360-degree area of enamel to get a more stable and long-lasting bond. This may not be possible with all endodontically treated teeth because one or more proximal areas you will have to bond to resin rather than to enamel. So how do you prepare? So this is just a set of burrs that I use for my preparation. The first, another important thing is that I'm avoiding naming any particular brand. If you specifically want to know the brand of burrs or any other material that I'm using, you can message me and I will share the detail with you. So in the interest of, being neutral, I do not want to name any brands here. So these are the burrs that I basically use for my partial coverage preparation. The first burr is a depth marking burr, is a occlusal depth marking burr. This is used to create occlusal grooves that are exactly 1.5 millimeters in depth. Okay. After making these depth grooves, the second step would be to do a gross reduction of the tooth. That is, all the areas between these depth marks are removed. For this, I use a round burr that is about 29 millimeters in diameter. I think 25 to 29. It's a very large round burr. The reason I use a round burr instead of any other tapered burr or anything is because most of the preps I'm talking about are done in molars. especially in the case of second molars, we have very small vertical space where a lot of burrs have a lot of difficulty fitting in. So a round burr can just be fitted in from the side, and you can do your crown preparation from the buccal side or from the lingual side. Okay, it's easier to do it with this particular round burr. After the gross preparation is over, we bevel the enamels, especially on the buccal side and the lingual side or the palatal side. This is done using a large round end tapered burr. Okay, this has to be a really large burr. The grit of the burr should be fine grit, or it should be a red band burr. Okay, this is the third burr that I use for my preparation. The fourth burr that I use for my preparation, especially for breaking the proximal contacts, is a very small round burr. This round burr is like probably about a millimeter in diameter, or even sometimes less than a millimeter. This is used to just break the contact and create space for the following burrs. I use the next two burrs. One is roughly a chamfer kind of a burr, and another one is a round and very thin round and tapered burr. Both these burrs have to be red band burrs or fine burrs, fine grit burrs. These burrs are used for proximal smoothing, proximal beveling, and finishing the tooth preparation. I usually end by finishing my restoration with mostly with a Shofu Softflex disc. Shofu, it's not a Softflex disc, it's a Super Snap disc. There's a black color Shofu Super Snap disc. I use it to smoothen my entire preparation. That would be the final one. Now, once the preparation is done, you've taken the impression and all those things, and your restoration is here, you're going to bond the restoration. So what is the bonding protocol that I use for the restoration? Okay. So this particular bonding protocol is very specific to lithium disilicate. There are some steps that I slightly modify in my clinical practice. I will say what would be ideal and what I actually do. So step one in the bonding protocol would be to first treat there are two substrates that you're bonding. One is the restoration and the other is the tooth surface. So you have to first treat these two substrates to be able to bond them together. So first we need to treat the lithium disilicate restoration. You will probably first try in your restoration. Your first step would be to try in your restoration. After you try in your restoration, you have to clean the intaglio surface of this restoration, this overlay or crown or whatever. Okay. What I use is sodium hypochlorite. But by the book, what you need to use is you need to use isopropyl alcohol in an ultrasonic bath for about 5 minutes. I very rarely do this. What I use is just sodium hypochlorite. I just inject some sodium hypochlorite onto the intaglio surface. That takes care of any organic debris that is there on the intaglio surface. Then I just clean it with a water spray. The second step would be to etch the surface of your restoration with 9% of hydrofluoric acid. This is usually done for 20 seconds. Few seconds more, few seconds less. It's not the end of the world. Okay. 20 seconds is what is recommended. You do it for few seconds more. Your world is not going to end because of that. You then wash it and clean it with a 3-way syringe. Again now, what happens is when you etch the surface of the restoration, it produces certain loose silicate salts. These silicate salts can interfere with the bond strength of the restoration to the tooth. So what is ideally recommended by the book is to put the restoration in an ultrasonic bath and agitate it for about 5 minutes. Alternately, some key opinion leaders in this field have advised using phosphoric acid and scrubbing it for about a minute on the restoration surface. To be frank, I don't do this step. I completely skip this step. I have checked the surface after etching under very high magnification, and I have checked the surface after cleaning it with phosphoric acid and after cleaning it in an ultrasonic bath. physically I'm not able to see any sort of change in the surface. So I generally skip this step. If you want to be absolutely by the book, then follow this step. But personally, I have stopped doing this step. And the final step would be to treat the surface with a primer. In the case of lithium disilicate, the primer that you use would be silane. Different kinds of silane are available in the market. Anything is absolutely fine. Okay, you just put a drop of silane onto the surface. What I do is I allow it to just air dry. What is recommended by certain key opinion leaders is that it has to be allowed to sit for about 20 seconds, and then it has to be air dried with warm air. Okay, this is what is usually recommended by certain key opinion leaders. But what I do is generally I don't air dry, I just allow it to evaporate. Now, while your primed restoration is evaporating, you can use the time to treat your tooth. Okay, in this case, again, first step, you're going to have to clean the tooth surface. You can clean it again with, there are commercially available materials that can be used to clean the tooth surface. I don't use that. I again still use sodium hypochlorite to clean the tooth surface. My second step would be to air abrade the tooth surface. Now, if you had paid close attention to that slide where I, in which I told you that when an indirect restoration is bonded to a tooth following certain protocols, okay, one of those protocols is air abrasion. This is something that you cannot skip. Okay, you need to air abrade the prepared tooth surface before you try to bond to it. Okay, if you wish to get the kind of bond strength that we spoke about earlier. So how do you air abrade? You use about 27 micron alumina at a pressure of about 60 pounds. Now, air abrasion units, initially, like say about 3 years ago, the only air abrasion units that you could get cost around 1.5 to 3 lakhs. But now you can get air abrasion units for as low as 4,500 rupees. It is possible. If anyone is interested, you can message me later on and I will direct you to where you can buy these air abrasion units. After air abrasion, the surface of the tooth has to be cleaned with your 3-way syringe. Okay. After cleaning it with the 3-way syringe, you need to apply a layer of some sort of universal bonding agent. Okay, it usually what we are going to use to bond the restoration to the tooth is going to be a dual cure resin cement. Most of these dual cure resin cements will come with some sort of adhesive or some sort of universal bonding agent that will have to be applied onto the tooth surface and has to be cured. This has to be done, and after that, the restoration is bonded to the tooth surface using a dual cure self-adhesive resin cement. Again, brands and everything, you can message me later and I'll give you the brands that I use and any alternates also. Now, I just wanted to share a case, just to give you a perspective of what in the scenarios in which you will be expected to restore endodontically treated teeth. Okay, now take a look at this particular tooth. Okay, traditionally, say about 5-6 years ago, if I was going to restore this tooth, I'll probably place a post. I will build up the tooth vertically. Then I will go about prepping the tooth, giving it a perfect margin, clearance and all those stuff. In the process of prepping the tooth, I will get rid of whatever remaining residual enamel and dentin that is there. And I will probably end up placing a crown on top of the tooth, and God knows how long it is going to last. But in this case, what I did was I first just restored the access cavity with a bonded restoration. Okay, and I didn't even prep this tooth. I just smoothened it out with the shofu disc, and I took an impression and I gave a restoration like this. This particular case was done in 2022. This was a patient from Malaysia. They almost come every year, and in 2022, I did not have the confidence I have today in regarding these restorations. And every time I see this case when the patient comes to my clinic, it gives me more confidence in this whole partial coverage restoration journey. Okay, so this is just one case which is an example. Now, if you want further convincing with regards to partial coverage restorations, I would like to present more literature evidence to support the same. Okay. This was an article that was published in Journal of Adhesive Dentistry in 2018, and this was a scoping review regarding the success rate of partial coverage restorations. Okay, and this scoping review found partial coverage restorations, ceramic restorations, to have anywhere from 96 to 99% success rate. Okay, there were some cases where it was like 90%, but overall it was like 96 to 99% success rate. Okay. This was another study. This study is often quoted in social media. This was a study where both partial coverage restorations and crowns were made of different thicknesses. And the take-home message from this particular study is that a partial coverage restoration of 0.5 millimeters was found to have more load bearing capacity than a full crown of the same 0.5 millimeters thickness. Material, same material. Only difference was one was a partial coverage and the other one was a full crown. Partial coverage was found to be able to withstand more load compared to full coverage. This was another review that was published in the year 2024. This is more recent, and this one found a survival rate of 83 to 97%, I think. Okay, and also this particular review tried to study what is the most common modes of failure, and most common modes of failure were mechanical failure like retention loss or ceramic failure, ceramic fracture or something like that, but the tooth was still intact. So as long as the restoration only failed, the tooth was re-restorable. Okay, this is a very important point. In the case of a crown, we are going to have catastrophic tooth fracture. In the case of a restoration or a partial coverage restoration, we are able to save the tooth even if the restoration is lost. Okay. Finally, this is a less important. This is a more of a short-term study. They studied the success of partial coverage restorations over a period of 3 years, and they found them to function almost as well as full coverage crowns. So finally, just to encapsulate whatever we learned today. Okay, why do we want to do partial coverage? Because first thing, we are conserving natural tooth structure.
Sir, you're not audible.
So you're not audible as well as visible.
So you are being muted, I think.
Yeah, I just connected back. Sorry for the inconvenience. I'll just share my screen and I'll restart from wherever I left off. Doctor, you able to see my screen?
Yes, sir.
No, sir.
Yes,
Yeah,
sir.
so I hope this was the place where I left off, right? Or was it
No,
the
sir.
previous slide? This slide?
No,
No, sir.
no, sir.
Slides are not visible.
Okay, slides are not visible. Okay, 1 minute. I have shared my screen. 1 minute, 1 minute. Just please hold on.
Only you are visible.
Yes.
Okay, fine.
Yes.
Okay, was this a slide where I stopped?
Yes, sir.
Okay, fine. So let me, again, I apologize for the inconvenience. Just got disconnected all out of the blue.
09.
Okay, are we good? Can we start
Yes.
again?
Yeah.
Okay, fine. So why partial coverage? First point is that it conserves tooth structure. You are not removing undiseased enamel or dentin. Second point is you get a better coronal seal. One of the reasons for which you give a restoration on an endodontically treated teeth is that you want a double coronal seal. So you get better coronal seal with a partial coverage restoration. Why? Because number one, the marginal gap between the restoration and the tooth is less than 1/10 the size of a bacteria. So there is no chance for any sort of marginal leakage. Second, most of your margins are invariably supragingival. So supragingival margin is more cleansable. So there is less chance of any secondary decay forming under the margins of the restoration. Okay. Another advantage using partial coverage is that you are using a ceramic material. Bonding material to the underlying tooth actually strengthens the ceramic. Okay. Fourth point, it prevents catastrophic tooth fracture. Okay, this is the most important. This was what the first 4 or 5 slides were about. This is the most important reason why I personally choose to go for partial coverage restorations. It extends the restorative life cycle of the tooth. See, most uh, teeth will go through a certain cycle. You first do a filling, then that filling becomes larger, then the filling keeps getting larger. Then after a point of time, there is a pulp exposure. You do a root canal, then you give a crown, then the tooth fractures, then you go for a implant. So each tooth has a certain life cycle. So by doing a partial coverage restoration, we are extending the restorative life cycle of the tooth. Now there are certain key factors that will decide how successful or unsuccessful a partial coverage restoration is going to be. Unfortunately or fortunately, I don't know, it depends on your perspective. A partial coverage restoration done on a vital tooth is a lot more successful than a partial coverage restoration done on a endodontically treated tooth. Okay, and in this case, when we say more successful, it is not that the tooth is going to fracture. It is just that we need to be more careful with our bonding protocol so that the restoration does not dislodge or fracture. Okay. Material selection. Lithium disilicate is the gold standard. There are other restorative materials. Zirconia, it is possible to bond zirconia to the tooth. There are materials such as 3D printed ceramic filled resins, which I myself have tested in my practice. But all these are materials that are not yet ready for the main event. Okay. Lithium disilicate is your gold standard as far as bonded partial coverage restorations are concerned. Technique matters. Techniques such as immediate dentin sealing, resin coating, using rubber dam isolation, using appropriate materials which will reduce your polymerization shrinkage stress on the tooth. All these techniques will contribute to the success of your partial coverage restoration. Finally, patient habits. You can give the most beautiful restoration, the most perfectly technically perfect restoration. But you need to understand that a patient's mouth is one of the most hostile environments in his body. The minute you send him out, you don't know what he's going to put in his mouth. Okay. So in the case of people who are smoking, people who are bruxers, people with poor oral hygiene, the results can be unpredictable. Okay. It is out of your hands. So do not beat yourself up when you face your first failure. It may have nothing to do with your technique. Okay. Finally, your prep design, your restoration design, the thickness, 1.5 mm of thickness, all these will contribute to the success of your restoration. So this is where I make my final provocative statement. In about 5 years of time, you have a younger generation of dentists coming into the field. For them, this is going to be the minimum acceptable clinical standard of restorative dentistry. They are not going to be doing crowns. Okay. So if you are a practicing dentist right now, learn this technique. At least start investing some time to learn this technique. Okay. You can go to my Instagram account. You can go to my YouTube account. You will find 5 years of content there specifically on this particular topic. It is all free to watch. You do not have to pay for anything. Okay. Start learning this technique. It is something that you shouldn't be doing crowns on teeth that have conservative access cavity preps. Okay. So this is why I say partial coverage is not a trend, because a lot of people now believe that this is just a trend, just like cosmetic dentistry or aligners or something that is just becoming very popular right now. No, this is not a trend. It is the minimum acceptable clinical standard of restorative dentistry that everybody, even if you are at an undergraduate level, you should know this. You should know the science behind it. You should know the techniques behind it. You should know how to prep a tooth to receive a partial coverage restoration, because this is not something that is good. Patients who are going to be doing partial coverage only. Okay. And I make this prediction. Okay. And after 20 years of clinical practice, I have completely changed my and my belief in what is right and what is wrong. Okay. And I believe this is the right way to restore a tooth. Okay. So do your research, do your further reading, whatever is required. I am always available to answer any questions you have. You can just message me on Instagram and I'll be more than willing to answer any questions you have. So if you have any further doubts, or if you're not able to ask any of your questions during this particular question session, you can just ask me these questions on my Instagram account. The QR code you see on the screen will take you to my Instagram account. You can just give me a follow and ask me whatever questions you have on your mind. Finally, I'll again thank Dr. Shanu Dr. Joanna and IADP for giving me this opportunity. I know that this probably is not a very elaborate lecture covering all the nuances of this topic, but I try to make believers out of. If you are here today, it means that you want to learn about this topic, and I hope I have made converts out of a few of you. So thank you. I'm ready to take questions, Dr. Joanne.
Sir, can you please give few tips to follow to reduce polymerization shrinkage?
Okay, so tips for reducing polymerization shrinkage. So okay, let's just I do not have any pictures right now, so let me just give you an example. You have a endodontically treated tooth. You have an access cavity preparation that is probably about 6 millimeters in depth, right? So the first thing you do is, first step, you Yarrow braid the surface of the cavity. Okay. Second step, you use a gold standard bonding agent. I'm not naming brand names here. You can message me later and I'll give you brand names. Okay. Use a gold standard bonding agent. Then you wait for 5 minutes. Why you wait for 5 minutes? Because the time taken for a dentin bond to mature is longer than the time taken for an enamel bond to mature. Okay. After 5 minutes, you put your first layer. Your first layer of composite will always be a flowable composite of low polymerization shrinkage. Okay. In most cases, what I usually advise is using a flowable composite, a short fiber reinforced flowable composite. Okay. That should be your first layer, and you adapt it to the floor of the tooth and you cure it. The second layer, which should be just 1.5 millimeters in thick, should be a short fiber reinforced packable composite. Okay, that is your second layer. After that, every additional layer should not be thicker than 1 millimeter. You do a very slow incremental buildup of the access cavity preparation. Okay. It has been shown in several studies that the amount of polymerization shrinkage when you do a incremental filling of your access cavity is significantly lesser compared to when you do a bulk fill. There are a lot of materials available in the market which claim to be bulk fill materials. Materials that can cure up to a depth of 6 millimeters, materials that can cure up to a depth of 10 millimeters, materials that will cure in 1 minute. Yes, everything will cure, but as they cure, they are also going to shrink. Any resin will shrink. Okay. It is only the shrinkage, the effect of this shrinkage can be reduced only if we use techniques like this to reduce that shrinkage. So basically, let me just summarize this again. Yarrow braid, use a gold standard bonding agent, wait for 5 minutes. First layer of flowable resin, short fiber reinforced flowable resin. Second layer, 1.5 millimeters thick of packable short fiber reinforced resin. Then any packable resin in 1 millimeter increments. This is how you restore a access cavity. It takes time, and all this should be done under rubber dam isolation. Okay. If you're not doing this entire procedure under rubber dam isolation, it is kind of pointless. So hope that answers your question.
Thank you, sir. One more doubt. What about beveling for posterior tooth?
Beveling, anything specific you want to know, doctor, regarding beveling? Because
Sir, like if we give occlusive bevel for posterior tooth,
okay.
gauge be more likely to increase or something like that?
Okay, see, traditional crown preparation requires you to bevel only the functional cusp, right? So in the case of a overlay or a partial coverage tooth or a tabletop restoration, you have to give a 360-degree bevel of your enamel. Okay, the reason why you want to give a 360-degree bevel is, number one, increase the surface area of enamel that is going to be in contact with the ceramic restoration. The second reason, and the more important reason, is that the bevel actually helps in converting the any transverse forces or tensile forces that are applied onto the restoration into compressive forces. The bevel actually is a design feature that will convert any tensile forces that are applied onto the restoration into compressive forces, and this compressive force goes to dentin. Dentin being resilient, it is able to dissipate these compressive forces better. Okay, hope that answers your question.
Thank you, sir.
Yeah.
Hello, sir. I just wanted to ask you just said that we should not reduce the cusp. But, sir, after RC, the first step that we need to do so there is no pain, that is occlusal clearance. So, how do we?
Okay,
Uh,
doctor, you do cuspal reduction for two main reasons. One is for length control, and another one is to so that the patient doesn't have any post-operative pain after the root canal is completed. Okay, so with regards to length control, okay, it is not mandatory to have a flat surface to have absolute length control. You get endomotors now which are able to measure your canal length simultaneously along with instrumentation. Even that not being an option, you can still use a cuspal tip, even if it is a sharp tip, as a area of length control. See, in my practice, I do all the endo. I'm a prosthodontist, but in my practice, I do all the endo. I do not reduce the cusp of any of the teeth that I am doing endo on. Okay, there is no problem with any sort of, you can go and look at some of the cases that I've shared in my Instagram account. You will not see any sort of compromise as far as length is concerned. The second reason is post-operative pain. Now, post-operative pain, just blindly, reducing, if post-operative pain is going to be there, it is going to be there. There are ways to reduce post-operative pain, not be, over instrumenting the canal, not, going beyond the apex when you are instrumenting the canal. There are various, I think an endodontist would be a more apt person to talk about this, but there are ways to avoid post-operative pain. And even if there is post-operative pain, you are still going to medicate the patient immediately after you treat them. You are going to give them some sort of painkiller. And irrespective of whether you reduce the cusps or don't reduce the cusps, the patient is going to have some sort of discomfort there on the first day. That is a given. Okay. Why we are not reducing the cusps is because when we prepare the tooth, okay, when you restore and prepare, I usually what I advise is you have to restore the tooth to full contour. Okay, when you're doing your entrance restoration, you have to restore the tooth to full contour, proper perfect occlusion, and then prep your teeth. This is what I usually advise when prepping for partial coverage restorations. Why we want to do this is because you want to follow the morphology of the tooth when you are prepping the tooth. You make your grooves, depth grooves, and all those things. You don't want to prepare a flat surface which doesn't have any kind of, doesn't provide any sort of positive seat for the restoration. Okay, when you place your restoration on the tooth, if the tooth is, tooth prep is morphologically guided tooth prep, when you place the restoration on the tooth, there is a positive seat. There is only one way the restoration will go onto the tooth. If you have already flattened the tooth, your prep is also going to be absolutely flat. And there is not going to be any sort of guide for you to guide the restoration onto the tooth. Those are the cases where some people will give some sort of a seating, sleeting slot in the middle of the tooth, and that has its own disadvantages. This is a very elaborate answer. I hope I've answered this to your satisfaction.
Yes, sir. Thank you so much.
Yeah.
Sir, I
Sir,
have one question.
Yes, doctor.
Sir,
very good.
I'm doing this bonded restoration since more than a year, but
Okay, doctor.
my only doubt is in case if any of the restoration fails, how to remove this bonded Emacs restoration? Is there any way
They
to
are very
remove it?
difficult to remove, doctor. You will have to cut it like how you cut a tooth and remove.
Okay, sir. Thank
You
you.
literally have to prep the completely prep and remove the restoration, because if it has been properly bonded, it will not flick off or chip off.
Okay, sir.
You will
Okay.
have to, see, Emacs is a very soft tooth. You can just use a diamond burr to cut through the restoration. It's easy to cut through, but you cannot use a crown remover or, some sort of, the WAM key or something like that to, remove the restoration. It will just not come out.
Okay, sir. Thank you.
Yes, doctor.
Hello, sir.
Yes, doctor.
Sir, I wanted to ask, how do you temporize the tooth after prepping?
Okay. After I prep the tooth, I apply a layer of Vaseline on the tooth. And are you aware of liquid dam that is used for rubber dam isolation?
Yes, sir. Yes.
Yeah, I just inject a layer of liquid dam, I lock it in the interdental spaces, and just build it up until it touches the opposing tooth. That's all. That is my temporary. And when the patient comes back, I just flick it off and bond the restoration.
Thank you, sir.
Yes, doctor.
So can you tell me about the advantage of using, which is better to use self-etch bonding agent or it's both separately?
See, again, I can't name brand names here, so I will not name the brands. Whatever gold standard bonding agents, there are two bonding agents which are believed to be gold standard bonding agents. These bonding agents are, one of them is a three-step bonding, has a three-step bonding protocol. The other one has a two-step bonding protocol. For one, you will have to etch. For the other, you have to air abrade. Okay. Those bonding agents were actually mentioned in the presentation, but I didn't mention them by name. So one of them is a 3-bottle system. You have to etch, you have to prime, and then you have to bond. The second one comes with a self-etching primer with a mild acid. Okay. It has MDP, which is slightly acidic. So that MDP kind of acts like an acid etch. But before using the primer, you have to air abrade the surface you are bonding to. Then you prime and then you apply the bonding agent.
So, which
Yes,
air
doctor.
abrasive system you are using, sir?
Okay. Again, I'm not naming names. There is one particular air abrasion system which you will find online. You can just go search intraoral sandblaster. Okay, this is available with a local vendor here. It's around 4,500 rupees. That was the first one I used. After that, I used another air abrasion unit I bought on AliExpress. Okay, it was a no-name brand. It was about cost me around 10,000 rupees to buy it from AliExpress. So if you have someone living abroad, you cannot order stuff and get it delivered in India from AliExpress. So you'll have to order it, get it delivered to someone outside India, and they'll have to carry it and bring it here. So that was one I ordered from AliExpress. That's fantastic. That's probably the best air abrasion unit I've used. Of the 3 units that I'm using right now, I would consider that the best one, because it's quite aggressive. It rarely gets clogged, probably gets clogged once or twice in 3 months. Okay. It's a fantastic unit. The third one I bought from a local vendor. It kind of works. That is what I can say. It works. It is not the best unit you can buy, but it works. And that unit was around 20,000 rupees. And it works. But the problem with that particular unit is that it kind of gets clogged very often. And even before it gets clogged, the efficiency of the unit kind of starts slowly. You clean it. I have to clean it every time it gets clogged. I have to clean it. And after cleaning it, I start using it. The first time I use it, it is very effective. But as I continue to use it, the efficiency kind of reduces, and at one point it comes and becomes zero. And there is no indication that it is clogged or anything like that. So I found that to be a problem with that unit. But right now I have been using that unit for about 3 months now. It works. It's not that it doesn't work, and you get what you pay for. Okay, these are like the first unit is around 4,500 rupees. The second one is around 12,000 rupees, and the third one is around 20,000 rupees. I would say we are blessed to have these units right now, because any other air abrasion, you will have to buy units you want to buy. It's like in lakhs, 3 lakhs, 8 lakhs. Okay, just for air abrasion, spending that amount of money doesn't make sense to me.
Sir, 27 micron abrasive, that is also not very easily available, sir. So from
No,
where we can get?
it is available with a couple of vendors, doctor. You can message me later, and I will share the details of those vendors to you. You can message me on Instagram if you want.
Sir, we
Sir,
need
good evening.
to, sir,
Yes, doctor.
we need to cure the tooth, sir, after bonding.
Cure the tooth after bonding. Can you be a
I'm
little bit more?
asking for overlay.
Yes, doctor.
Overlay.
You after placing the overlay, you asking me if
No,
we
no,
have to
no,
cure?
no. We have to bond the tooth separately. No, that should be cured or not.
Okay, you were asking me before placing the tooth before placing the restoration on the tooth, we are applying a layer
Yeah,
of bonding agent, right?
yeah. That should be
That
cured
is
or not.
usually a universal bonding agent, doctor. It has to be cured. The only bonding
Oh.
agent that doesn't have to be cured in thickness. These bonding agents, if cured, will interfere with the. I hope you're able to hear me. There's
Yes,
some
yeah.
issue with the internet. Yeah, okay. These bonding agents, if cured, will interfere with proper seating of the restoration. So these bonding
Oh.
agents shouldn't be cured. But any universal bonding agent will only form a film thickness of about 10 microns, and they will not
Okay.
interfere with the seating of your restoration. So if you're using a universal bonding agent, universal bonding agent meaning any 7th or 8th generation bonding agent, which is like a single bottle system, then you can cure it without any fear. It will not cause any interference with the seating of your restoration.
Okay, sir.
Sir, IDS, sir,
Sir,
we
good
have to
evening.
do before.
You
Sir,
Yes,
about 3D
yes.
restorations, 3D resin restorations.
Okay, 3D printed resin restorations.
Is this,
My conclusion
yeah.
from whatever cases that I've done, they are not ready for the mainstream yet. Okay. First, because there is very little literature that actually is support using these restorations. In my practice, I use them more as a long-term provisional. See, some patient walks in, says, I'm not able to afford a ceramic restoration. So you give me a full coverage PFM crown. Instead of doing the PFM crown, I will give him a cheaper 3D printed resin restoration. Tell him to take 1 or 2 years, get financially prepared, come back and get the ceramic restoration done. Okay, that is why that is the only reason I use 3D printed restorations. Please be very clear. Current, irrespective of how much filler they say they have, current 3D printed ceramic filled restorations cannot be used as a permanent restorative material for any posterior tooth. Okay, be very clear about that. I'll make this absolute statement. They cannot be used as permanent, or nothing is permanent. They cannot be used as a definitive restorative material on any posterior tooth. They do not, as of now, have the wear characteristics or the compressive strength that is required to act as definitive restorations. The best material right now available has a compressive strength of about 203 megapascals. that doesn't even come close to the strength of enamel. Okay, so I wouldn't recommend them as definitive restorations. Lithium disilicate is the gold standard. So do not. I understand the question because in social media there are a lot of a lot of publicity being done about 3D printers right now. Do not follow the marketing. Okay, if somebody is most people are trying to sell 3D printers by saying that you can print permanent restorations chair side. No, not yet ready for mainstream practice. You can do veneers. Okay, it is possible to do veneers, definitive veneers itself, because they are basically composites, 3D printed composites. But posterior restorations, you have to wait a little longer. They will get there, but you have to wait a little longer.
Sir, immediate dental sealing, sir.
Yes, doctor.
The immediate dentin sealing, sir, that we have to do, sir, before making the scan or impression or after making the
Immediately
scan or
after you prep your teeth, doctor. Immediately after you prep your teeth, the freshly prepared surface of the dentin has to be sealed and a resin coat has to be done to protect that seal. And then you take the impression.
Okay. So, but when we temporize it, so that temporary material that gets stick to this material.
You use Vaseline, apply a nice thick layer of Vaseline on the tooth, lock temporary material. What do you use, doctor? You use something like Pro Temp or
Temp
something like
Smart,
that?
Temp Smart
Temp
I am
Smart.
using, sir.
Don't use that material. What I do is, I don't know if you paid attention. What I do
Yes, sir,
is
you were
I
telling
use
about that.
this thing, liquid dam, as a temporary material. Okay, the idea of giving temporary is to just avoid any mesial or distal drift of the tooth, and for preventing supra eruption of the opposing tooth. I do not go use Temp Smart or anything like that. That will stick to the tooth. Even if you apply Vaseline, it will still stick to the tooth. Liquid dam doesn't stick to the tooth. And even if it sticks to the tooth, you can actually use a sharp number 15 BP blade and just shave it off.
While we doing the entrance filling, we should do the immediate entrance sealing, or after the preparation is enough?
See, when you're doing entrance filling, you kind of do immediate dentin sealing. You are air abrading the surface, cavity surface, and you're applying a gold standard bonding agent. So what happens
Primer
is,
plus bond.
yes, primer plus bond, and then you are waiting for 5 minutes. That 5 minutes wait, that is called decoupling with time. You allow for the bond to mature, the dentin bond to mature before you apply the first layer. Okay.
Sir,
So it is.
enamel also.
No, you don't bond to enamel. See, the bond strength immediately after you apply the bonding agent, right? This bond strength to enamel is around 30 megapascals. The bond strength, initial bond strength to dentin will only be 15 megapascals. Okay, it is like a tug of war between a bodybuilder and a 3-year-old child. Okay, so what enamel will do is pull the whatever restoration or whatever dentin bonding agent you use, it will just pull it away from dentin, which is why, if I don't know if any of you have observed, you will have a gap at the bottom if you do bulk fill. Okay, in any endodontic restoration, if you do bulk fill without waiting for the dentin bond to mature sufficiently, if you do a bulk fill, the entire restoration will get pulled towards, as it shrinks, it will get pulled towards enamel, because the enamel has the higher bond strength than dentin initially. But as the dentin bond strength improves, it increases from 15 megapascals to somewhere between 35 to 50 megapascals, where it can resist the pull, when the shrinkage happens, it doesn't get pulled away from dentin. Okay, so you actually are not doing immediate dentin sealing, but you are doing decoupling with time when you are doing your entrance filling.
After doing the resin coat, we should bond the enamel.
No, when you're doing incremental filling, right? The last layer is what will come in contact with enamel.
Okay. Okay.
Okay, when you're doing a bulk fill, you're filling the entire cavity in one shot.
Yes, sir. Yes, yes.
Okay, but when you're doing an incremental fill, you're going 1 mm, 1 mm, 1 mm. By the time you reach the top, it is about 10 minutes already. And your dentin bond has matured sufficiently. Your dentin
Okay.
bond strength will reach 95% of its highest potential bond strength in about 5 minutes. The remaining 5% takes about 24 hours.
Okay, sir. Okay. The same scenario should be followed for composite restoration also.
Yes, it's slightly different. If you're doing a composite
We
restoration,
should
the
use no,
protocol
sir.
is slightly different. You do not have to etch it. You just have to air apply a universal primer in this case. There are certain primers that are universal primers that have MDP, silane, and certain monomers that can actually bond to resin. Okay, you need to use a universal primer to bond a composite restoration to the tooth. You don't have to etch it, but you have to air abrade it.
For enamel also we no need to etch, sir.
No, I don't etch enamel because whatever bonding agent I am using, it is a has a self etching primer. So I don't etch enamel. I just air abrade. That's all.
Okay, sir. Okay, sir.
Sir, do you prefer of metal onlays or any specific cases where we, instead of doing lithium disilicate, we can use metal onlays?
Okay, Dr. Metal onlays are very similar to zirconia. So just like zirconia, we can bond to metal also. But how predictable and how good that bond is something that is a little unpredictable. Okay, I have not actually tried bonding metal. I have done one case where I have bonded a zirconia onlay. It still stays in place, but it is not something that I will repeat again. The problem with bonding to metal or zirconia is that the protocol is again a little different. You have to air abrade the tissue surface of the restoration with 50 micron alumina. Okay, 50 micron, it is basically sandblasting. You have to create a rough surface on the intanglio surface. With the kind of air abrasion units that I am using, I'm not able to get that kind of rough surface. I have to give it to the lab and ask them to sandblast it and send it back to me. Okay, then after you try it into the patient's mouth, you have to clean that surface. That surface gets contaminated. Okay, because it is a air abraded surface, it is almost next to impossible to completely contaminate the intanglio surface. Okay, so that is another problem that I face when I am giving a zirconia or a metal overlay. Okay, and then you apply a primer. So basically the protocol for bonding zirconia or metal is air abrade, clean, then apply a primer, usually a zirconia primer which contains MDP, and then you bond it to the tooth. Preparation for the tooth is the same for all types of restorations, but for metal and zirconia, my personal bias is that I don't think the bond strength is as predictable as what can be got with, say, lithium disilicate or with even a 3D printed restoration.
Sir, what about GC, like the cementation as we do for a normal crowns? Can only be cemented with a normal GIC?
Absolutely not, doctor. JAC doesn't bond. It is a pseudo bond. If you have removed JAC restoration from an entrance, you will understand that. JAC doesn't bond. Yes, it is acidic and it kind of mimics a kind of bond, but the kind of bond that you get with modern bonding agents is an actual chemical bond with the tooth. What you get with JAC is not a real chemical bond.
Thank you, sir.
So where do we place bevel and butt joint?
Bevels are in enamel, doctor. 360-degree bevel along the borders of the tooth. You have enamel around the tooth, right? So you bevel the entire enamel. It's usually a 45-degree bevel.
Depth marking bar is there, no, sir? 1.5 mm.
Yes.
That we should put on the grooves or
okay,
on
first depth marks should be in the grooves. should all be in the
Center.
grooves. Yes, the second depth mark should be at the highest point of all the cusps.
Okay, sir. Okay.
Sir, how to reduce the high points after bonding? Is it possible?
Okay. It is possible, doctor. You remove your rubber dam, check it and reduce it. But ideally speaking, your lab should give you a restoration without high points. Okay. If you have taken a proper impression, taken a proper bite and sent it to your lab should give you a restoration without any proximal interferences or without occlusal interferences. Okay, that is how I have trained my labs, and generally I do not get any issues with regards to high points. So I am quite confident when I deliver my restoration. Suppose accidentally you do get some high points, it is absolutely possible to use a fine burr to reduce high points. After reducing this high points, you will have to polish that surface. There are specific ceramic polishing tips that are available. They are available online. You can buy them and you'll have to polish that surface. You shouldn't leave a rough surface there. You have to polish off that surface.
So can we do this in deep bite cases also? Like the success is the same?
Absolutely, doctor. This is like literally can be used in any particular tooth. Even teeth that are considered absolutely impossible to restore can be restored with this technique. Just that it takes a lot of time and a lot of patience, but I wouldn't be so evangelical about partial coverage if I haven't had the kind of success that I've had in the past 5 years. It literally fits any scenario.
Sir, any
Sir, most of the
contraindication for same?
Yes, doctor. Can you repeat it?
Any contraindications of partial restorations, like for the specific case where you suggest better to do the full crowns? Any specific cases?
Specific cases. I'm trying to recollect if I have chosen to do full crown. See, any scenario where there is 360-degree damage to the tooth, okay, and there is a significant amount of tissue loss, then in those cases I probably would try to engage more subgingival tooth and try to get more mechanical retention than bonded retention. But those kind of scenarios are significantly rare. I can say with almost 95% confidence that since 2021, any tooth that I have endodontically treated has not been restored with a full coverage crown. There are cases where endo has been done somewhere else. Tooth has already been prepared for a crown. In those cases, I give a crown. But I fail to recall any case where I have been forced to go for a full coverage crown on my own cases. So this may be a personal bias, but I really haven't come across any case that I could say this is an absolute contraindication for full coverage crowns. I mean, partial coverage.
So, in most of the cases where we do RC, it is like class 2 and the caries is subgingival. In that case,
Yes.
how to restore it, like how to record the subgingival area when we are planning for a Emax restoration. We have to go for DME and we have to restore it
Yes.
with composite before preparation. What we have to do, like
You will have to do a deep margin elevation, doctor. There are different techniques by which you will have to do. You can do deep margin elevation. The simplest method is to use a heavy gauge rubber dam. A heavy gauge rubber dam will retract the gingiva at least 1 to 2 millimeters apically and horizontally. Okay. Second thing that you can do is to use a matrix which has a ledge in its design to go in between the tooth and the gingiva, so that you have a separation between the wet gingiva and the tooth. In very, very rare cases, you will have to use a copper band along with a matrix. This is called the matrix and matrix technique. These are all very advanced techniques. And even in even more rare cases, you might have to use an electrocautery to cut away some amount of gingiva to expose your margin. This happens in cases where there has been a lot of electrocautery or a laser to cut away the inflamed gingiva and expose your gingival margin. You will first have to do a deep margin elevation, raise the margin above the free gingival margin, and then do your proximal buildup, convert the cavity into a class 1 cavity, then do a incremental buildup and build up your tooth access cavity. Okay. When you prep, there is no problem as long as your bond of your deep margin elevation resin is predictable enough and has been good enough. You can bond your indirect restoration to a resin margin. There is no problem with that.
So whether
Okay, sir.
you will remove the pre-endo buildup, sir?
Whether I will remove the pre-endo buildup. See, there are scenarios where I can do a pre-endo buildup and where I cannot do a pre-endo buildup. If I am endo treating a tooth and the tooth is bleeding profusely, okay, there is no way for me to do a proper bonded pre-endo buildup. Okay, so I usually delay the proximal buildup until the bleeding stops before I do a pre-endo buildup. There are some studies which say that the sodium hypochlorite is used as a irrigation can interfere with the bond, but I have not been able to find a full text of that particular study, so I really cannot comment on that. But when I do my pre-endo buildup is usually after the tooth has stopped bleeding. If the tooth is not bleeding when I open it up itself, I do the pre-endo buildup and then start go for my instrumentation. Yes.
So is there any need for any post for a badly broken down teeth? And
I have not placed a single post, maybe rarely in an anterior tooth, but I have not placed a single post in a posterior tooth in the last 5 years. Most of the teeth are restored using some sort of partial coverage. I've come across teeth. You can go on again. I'm referring you to my Insta account. There are cases that I have posted there which traditionally would have required a post to be placed, but I have not placed any post. All my restorative work is done only depending on, say, a post only gives you mechanical retention into the canal. Okay. Whatever bond strength you're going to get with the fiber post also is very minimal. So I have not placed a post in any case that I've done in the last 5 years. Posterior cases, anterior cases I have placed, but posterior cases I have not placed a post at all. It is basically you need to believe in your bonding protocol. That is all. Once your bonding protocol is on point, you will have the confidence to do these cases without a post.
what and in this hello, yes, sir. So
Yes, doctor.
and
Go on.
is it necessary to give full coverage for endodontically treated tooth, or we can give inlay also?
See, the answer would be it depends. See, if a tooth, say, I'll give you a hypothetical scenario. Upper first molar, okay? If your access cavity has not crossed the oblique ridge, okay? If your access cavity has not crossed the oblique ridge, then you will give a partial coverage that stops at the oblique ridge region. Okay, I think I showed a case. Let me just see if I can go back in my presentation. Okay. Okay, this slide. Okay, I want you to not something that is completely intracoronal. Okay. In this case, I have completely preserved the distal marginal ridge and the distal cusps. This is possible if your access cavity is conservative enough and enough tooth material is present on that particular side. This is possible.
Sir,
Yes, doctor.
even if you are using a bulk fill, if we should do in an incremental layer. Am I right,
Yes.
sir?
The short fiber reinforced composites that I'm talking about are marketed as bulk fill materials. Okay, I don't use it as a bulk fill material. I use it as a material that has a very low polymerization shrinkage because it is short fiber reinforced, and I use it in an incremental build-up technique.
Okay, sir. Okay.
Sir, what magnification do you use, sir? Microscope? If yes,
No, I don't use a scope, doctor. I have two loops. One is a Zeiss loop that is around 3.5x, which I use almost, I would say, around 80% of the time. Rare cases in endo, I use a 10x amidentist loop. Sorry, 8x amidentist loop. Sorry, not 10x. 8x amidentist loop.
Amidentist.
Amidentist.
Okay, okay. So
It was a very recent purchase. It is good, at least for my purposes. I am coming from a 3.5x Zeiss loop, so I find it quite good.
What's the spelling, sir? Amidentist?
I think it is AMEDEN.
Yes.
Dentist, TIS. You will find them as sponsors for a lot of endo courses.
Okay,
They
okay.
sponsor a lot of endo courses all over India.
Okay, okay, sir. Sir, do you use a headlamp also, sir, for coaxial illumination?
Yes, doctor. With the Zeiss, I use the headlamp that came with Zeiss, and with Amidentist, I use the headlamp that came with this thing. The lamp that you're talking about, I think, is the Biolumix lamp, right?
No, no, no. I'm not aware. I'm just asking you.
Okay. There is a separate lamp that is being sold by a company called Biolumix. So I thought you were talking about that.
No, no. How do you do the recording, sir, of the clinical procedures?
Okay. Recording, again, I bought a head-mounted camera from AliExpress.
Okay, okay. Right. Thank you so much.
So, yes.
Sir, what
So,
post-op instructions do you give after the bonding? The bonding of the restoration?
What instructions do I give the patient?
Yes, sir.
Okay. First instruction is I tell them you eat whatever you want. No restrictions. Okay. Second instruction I tell them is by chance if this whatever I've stuck on your tooth comes off, bring it back to me in less than 48 hours. I will stick it back. These are the only two instructions I give them. I don't restrict them from eating whatever they want. I don't restrict them. I don't tell them you don't do this, you don't do that. I just tell them eat whatever you want, keep the tooth clean. If it comes out, by any chance it comes out, bring it back to me in 48 hours. That is all.
And sir, what about the abrasion patients? Attrition patients, sorry.
You mean bruxers?
Bruxers, yes, sorry.
Bruxers get a splint, a hard splint with an anterior bite plane, which they have to use in the night.
Even for a single restoration?
Even for a single restoration, they get. Because bruxers, see, there is no universal rule about how much force a particular bruxer uses. Okay. A normal bite force is around 20 kilograms. But these people can create force close to around, some people say around 2500 newtons. Bruxers. Okay. That will even break zirconia. So irrespective of if I suspect the person is a bruxer, he gets a splint. It is baked into the charges.
But sir, patient always complains about difficulty in the hard splints, like the wearing for the.
Don't give them a. I don't know how the splints work there, but what I normally do is my splints are very thin. They are almost as thin as a SX retainer. Okay. What I do is in the anterior part, I give them a anterior bite plane, which will disocclude the posterior teeth. So the splints are actually very thin. They only cover the occlusal part of the tooth and about 2 millimeters from the occlusal part. But the actual disocclusion happens because of the anterior bite plane.
So is there any name for that splint? Like how to communicate to the lab for the same?
You just ask them to make 1 mm thick splint with the anterior bite plane. They will do it. It's some people call it a Michigan splint, but it's not exactly that. It is just a splint with an anterior bite plane. Just call it a occlusal splint, 1 mm thick with the anterior bite plane.
Thank you, sir.
Any ortho lab should be able to do it.
So, how to remove the interdental cement? Because this is dual cure, so we have to be very quick to remove the excess cement. But sometimes
Okay.
it happens, the proximal context, we are not able to pass the floss after cementation. So even I got the saw. There is a saw, to open the contact by mistake. If the cement is not removed, we can use
Okay.
a saw. With saw also, it becomes very difficult sometimes. So how to
Okay.
avoid it, and using a saw is a proper way to clean the interdental cement, excess cement.
Okay. Okay. I do not know your clinical scenario, but I will say how I manage interdental cement. Okay. So what happens is that I usually use this liquid dam, right? I usually use that to carry my restoration onto the surface of the tooth. Okay. I place it onto the tooth. I remove the instrument. Then I hold it down with then my assistant holds down the restoration on the tooth, and I take a floss and clean the mesial and distal areas once or twice. Okay, immediately after I place the restoration. So if you have your chair side assistant, ask them to hold down the restoration so that you can pass a floss both mesially and distally to clean out whatever cement that is collected mesially or distally. This kind of, even the dual cure resin cement that I use sets very fast. It kind of sets within 30 seconds. And I have found that it works pretty well. I have never had any sort of residual cement after I have flossed that place. In the rare scenario that you end up with some amount of residual cement, either on the distal or on the mesial surface, there is a saw. You call it a saw. It comes in shofu, I guess, right? You use that thing to just pass it in between the teeth. The saw part will not damage the neighboring tooth. It has a proximal strip part and a saw part. The saw part will not damage the neighboring tooth. It usually goes through the cement quite easily. Okay, hope this answers your question.
Yes, sir, one more question. So what
Yes.
happens, many times I have seen the lab, they make the contacts very tight. The proximal
Yes.
context, I'm talking about the
Yes.
direct restorations, right? So
Yes.
in that case, how to communicate with the lab that they make a restoration in such a way that we can easily pass the floss between the tooth and the restoration? How to
Okay.
communicate with the lab?
Okay. There are two errors that the lab makes. Okay. One is if you're taking a digital impression, okay, and you're fabricating a Emax restoration. Most labs will print a digital model. Okay. When they print the digital model, they do not use the appropriate calibration settings for that particular resin, and that model will either slightly shrink or slightly expand. That can either cause an open margin or a margin that is too tight. That is problem number one. Problem number two is if you are again using Emax press, all the fabrication is done. Proximal, everything is done and tuned in. And after doing all this, the technician will go and apply a layer of glaze on top of the ceramic. Okay. So in the first case, ask your lab to get their printing in order. That will solve most of the problem. In the second case, ask the lab to check the proximal fit after they do the glazing. Or even better, what would be better to do is ask the lab not to glaze your restoration. Ask them to nicely polish your restoration and send it to you. In that case, you won't have these issues. Usually, these are the two most common errors. If beyond this, the lab is making some error, then I probably think it is time to change the lab.
Okay, sir. Thank you. Thank you very much.
Yes, doctor.
So charges for the partial bonded restoration should be same as the crown, or it should be higher?
Started this, say, in 21, beginning of 21, I was charging around 9,500. Okay, so I got disconnected again. So, am I audible?
Yes.
Okay. Fine. So, did you hear my entire answer, doctor? Or you want me to repeat it?
So please repeat
Please
it, sir.
repeat, sir.
Okay. So, can you just repeat your question again?
So the charges for the partial bonded
Yes.
restoration,
So,
should we charge same for the crowns, or?
no, first, I don't do crowns, but my charges for partial bonded restorations is significantly higher than what I'd charge for crowns, because the people in whom I'm doing crowns are people for whom this thing has already been done. What to say? Prep has a certain amount of prep has already been done, so the amount of work involved is very less. And in those cases, in most cases, I do not do a rubber dam isolation also for the prep. In the case of partial restoration, I have to do a rubber dam isolation for the prep and for the bonding. Okay, so the amount of time taken for a partial coverage restoration is significantly higher than what it takes for a full coverage crown. So I charge more. But again, charges are a personal decision. You have to charge how much ever you think you are worth.
Thank you, sir.
Okay. Any more questions?
Hi, doctor. If
Yes,
in
doctor.
case the bonding fails, how to bond again? Do we use the same protocol?
Okay. Once a restoration debonds, you have to see which is your point of failure. Okay. Usually this is indicated by where your resin cement is stuck. If the resin cement is stuck to the restoration, then your bonding has failed at the level of the tooth. If the resin cement is stuck on the tooth and there is no resin cement on the restoration, then there is something gone wrong with the protocol you used for the restoration. So all it involves is repeating everything all over again. Whatever bonding protocol how you treat the restoration, how you treat the tooth, just repeat the protocol as per book again, and you will be absolutely fine. You just need to find out at which point the bond failed.
Sir, how many seconds we have to sandblast air abrade?
Okay, air abrade depends upon the air abrasion unit. The first two air abrasion units that I use, they'll usually abrade within seconds, like maximum 5 to 10 seconds. The last one I said takes almost a minute. Did I answer the question or?
Yes, sir. Yes.
Yes. Any other questions or?
Sir, after preparation, in what polishing system should be used for print?
For the restoration or for the residual cement?
Restoration, sir.
Restoration, there
After
are
doing
ceramic
doing
polishing.
IDS and resin coat for
After doing,
smoothening the walls.
no. You're asking for
Before
the.
taking an impression. Right?
You don't polish anything before taking the impression, doctor. You just do IDS, you
Oh,
do a resin coat, then take an impression. That is all. You don't polish
oh.
or smoothen anything.
After preparation, sir.
After preparation, you can just use a, you get these discs from Shofu.
Yes,
There
sir.
is a
Black
black
color.
disc, blue disc.
Yeah.
So you can use a
Yeah.
Shofu disc to smoothen the tooth.
Okay,
Black disc.
sir. Okay, sir.
So in case of partial bonded restoration, especially the overlay, what we are talking about,
Yes,
there
doctor.
will be a junction between the tooth and the restoration, right? Though
Yes.
it is like it is a resin cement, so the film thickness is also very less. But how
Yes.
to hide that margin? Because I feel like over a period of time it will get discolored because of the resin in between the tooth and the restoration.
Okay, very good question. See, the resin doesn't cure completely. That is a problem here. You have something called as the oxygen inhibited layer that forms on any resin that is exposed to the external environment. Okay, so what you do with any sort of dual cure resin cement is you inject a little bit of glycerin. You can get glycerin from Amazon. Okay, there is something called as vegetable glycerin that is available on Amazon. You can buy it, load it onto a syringe, inject it along the margins, then cure through the glycerin. You will not have the discoloration after that. The reason why you get the discoloration is because the resin cement that is exposed to the environment doesn't cure completely because of the oxygen inhibited layer.
Okay, sir. After curing, is there any way like what you follow to polish that particular junction? So there will be a cement between the tooth and
What I usually do if I feel there is an excess of resin cement there, I usually kind of shave it off with a sharp number 12 BP blade, and after finishing that, I'll again use there are in the same Shofu polishing system. You get those last two discs. You just polish it. You just polish the using those two discs, final discs, or you can use any composite polishing system. It's not that you have to use only Shofu. You can use any composite polishing system and just polish off that margin.
okay. And sir, have you seen any kind of secondary caries in the particular tooth where you have given a partial bonded restoration?
Yes,
Because the patient is
yes,
not able to maintain good oral hygiene. Then how to
yes.
deal with that?
I have seen that in, I would say, around 4 or 5 patients where the oral hygiene has been very bad. There is decay under the restoration.
Then how to deal with it, sir?
The only option here would be to remove the entire restoration and redo it. Excavate the decay and redo it. That is the only option left.
Okay, sir. Thank you. Thank you very much.
Yes, sir.
Approximately how much clearance we need to give, sir, when doing
Approximately
the
meaning,
welling?
doctor?
In the preparation, mesial and distal.
Mesial and distal, see, there is no, see, your proximal regions are not going to be under any sort of occlusal load. Okay. So basically,
It should not be
occlusally,
straight.
pardon me?
It should not be straight.
I don't understand the question, doctor.
So
Straight
the
meaning?
beveling the tip should not be straight. It should
See,
be blended.
usually in traditional onlay preparation, what you will do is you will prepare a proximal box, right?
Yes,
So
sir.
what you do in the case of a bonded restoration is that you don't prepare a box. You still prepare a box, but you merge that box with the occlusal preparation.
Okay,
Okay,
sir.
to
Okay.
make it look like there is no box.
Okay, sir. Okay.
Okay, so there is not exactly anything like a clearance in your see again I have to direct you to some of the videos that I have posted on my YouTube channel. If you see that, you will understand how I am doing the proximal, breaking the proximal contacts. I use a very small round burr to go proximally and gradually remove some material to create that proximal gap. Okay, it is not
Okay, sir.
exactly a proximal box what I do. Okay.
Even if we didn't emerge in the preparation, we can do with the flowable resin coat.
Yes, that is like a little bit of a compromise, but yes, that is also possible. If you have a box, you can just use flowable resin to merge that box with the occlusal preparation.
Okay, sir.
Sir, last question from me, sir.
Yes, doctor.
Sir, we talked about the secondary caries. Recently, we had a full mouth rehabilitation case. It was all bonded restoration, but
Okay.
in some cases, like in some tooth, the tooth surface is exposed, right? It is not completely covered because it is a bonded restoration. So, in
Okay.
that case, if the patient is not able to maintain very good hygiene, is it okay if we apply topical fluoride application? So, we can avoid the secondary caries for at least for some time.
Doc, secondary caries development on the buccal, lingual, or palatal surface is very rare. If secondary caries is going to develop, it is usually in the proximal regions. Okay. So if there are any areas where you will follow up the case, right? Like 3 months, 6 months, like that. So when you follow up the case, if you see food lodgement in any proximal area, just ask the patient to floss properly. They will not develop secondary caries. The trick is to catch it early. If you find the etiology early and treat it with home maintenance, you do not have to treat the problem. Fluoride application is an option, but it is not like you're not going to be able to get fluoride in all spots that are actually susceptible to decay. Yes, you can apply fluoride on the buccal and palatal and the lingual surfaces of the tooth, but those areas, secondary caries development is very rare because they are easily cleansable. You develop secondary caries only in areas that are not easily cleansable.
Okay, sir. Thank you. Thank you very much.
Yes, doctor. Anyone else?
Sir, for upper premolar, how we need to do depth marking?
Upper
Depth grooves.
premolar, one depth mark from marginal ridge to marginal ridge in the center. One depth mark on the cusp, tip of the cusp on both sides. That is lingual. That is buccal and lingual. Okay. If the tooth is large enough, then make one more depth mark near the marginal ridges. Okay, that should be done. If the tooth is small, just one depth mark in the central groove and depth marks in the height of, tallest point of each cusp is more than enough. Small teeth.
Okay.
So, okay, somebody has asked about bond maturity concept. It's not exactly bond maturity concept. It is what is called as decoupling with time. So, as per literature, the bond strength to enamel matures almost immediately. So the highest potential bond strength to enamel is around 35 megapascals. But the highest potential bond strength to dentin is about 52 megapascals. But this potential bond strength that doesn't develop immediately. When you apply a bonding agent and cure it, the immediate bond strength to dentin is only 15 megapascals. But as time progresses, okay, maybe 1 minute to 5 minutes, by the time it reaches 5 minutes, the bond strength increases from 15 megapascals to somewhere close to 35 to 40 megapascals. And after 24 hours, it actually reaches about 50 megapascals. So this time that is taken for the bond strength to dentin to mature, okay, allowing for this time is called allowing for decoupling with time. Okay. In direct restorations, where you are doing the restorations immediately, what you normally do is you don't have to wait for 24 hours. What you normally do is apply the bonding agent, wait for 5 minutes before you apply the first layer of resin on the bonding agent. This 5 minutes is enough time for the dentin bond to mature from 15 megapascals to 35 megapascals. Okay, so your restoration, whatever composite restoration you do, is retained better. Okay, this is called decoupling with time. Okay, we are actually decoupling, meaning you're decoupling the bond to enamel and the bond to dentin using time. That is all.
Sir, we can apply the primer and bonding in cervical enamel also, sir.
Yes, nothing.
Only in the
when
occlusal
you're using a 2-bottle system with only a prime and a bond, you have to aerabrate.
Okay, sir.
Okay, without aeration, it doesn't work.
Okay, sir.
Okay, somebody has asked me about heated composites. So personally, I don't use heated composites. I kind of follow Professor Marcus Platz as kind of like a mentor and a guru. So according to him, when there is already commercially available materials that are meant specifically for a purpose, then why use something that is not evidence based? So I have never used heated composites for the sake of bonding indirect restoration ever. I probably might try it out in the future purely for fun's sake, but it's not something that I've ever done till now. Okay, a lot of questions. Thank you. Very informative. Heated composites. Thank you, sir. Okay. Okay, did I miss any questions that were sent in the chat? I see a lot of messages in the chat.
We should reduce functional cusp more, sir. Than
Pardon me, doctor?
We should reduce the functional cusp more than a non-functional cusp.
No, doctor. That is only in the case of crowns. Here,
okay,
you need a uniform space of 1.5 millimeters. That is all. And a 360-degree bevel. Done.
Oh.
Okay, somebody has asked me if paracore system can be used for filling RC treated teeth. I am not familiar with that particular material, doctor. So I cannot comment on it. Okay, somebody has said is a vital tooth. Let me see the question again. Is the vital tooth the best candidate for PCR or any points to remember? What special instructions you give the lab before fabrications? Special instructions to the lab, nothing in specific. I just ask them to give me if it is a molar to molar contact, I ask them for a broad contact. If it is a premolar to molar contact, I ask for a point contact. But again, that all changes from tooth to tooth. It depends upon the morphology of the tooth. And with regards to vital teeth, yes, there are specific vital teeth where after you prepare the cavity, you will see that the the cavity walls are very thin. In that case, you will have to go for cuspal coverage, and in these cases, partial coverage works beautifully. Okay, they are far more successful in vital teeth as compared to non-vital teeth. Yes. Any more questions? So are we done?
Hello.
Sir. Yes, doctor.
Yes, sir. Dr. Sri Kishan from Rajasthan. Sir,
Yes,
I
doctor.
want to say about education program of any book suggestion about.
Books. There is a particular book by Dr. Pascal Mania called Biomimetic Restorative Dentistry. It's a great resource. Only problem is that that particular book is written by someone for whom English is not his first language. So it may be a little difficult to understand. But that book is kind of considered a Bible as far as any indirect restorative work is concerned. Okay, so that is something that I would recommend.
Thank you.
So anyone sending questions in the chat, please, you can ask the question directly. It's kind of difficult to keep following. So some Dr. Deepalakshmi has asked, sir, onlays are not working. So I would request Dr. Deepalakshmi to elaborate a little bit more on that. She can unmute herself and ask me that question before I go to the next question.
Hello, sir.
Yes, doctor.
Yeah, I'm Deepalakshmi, sir.
Yes,
Sir,
doctor.
I used to give onlays in root canal treated tooth. But what
In?
happens is in root canal treated tooth?
Okay, doctor.
But what happens is in the long run, within 6 months or 1 year, it
Okay.
Decementation occurs, sir.
Okay,
Or else the
fantastic.
tooth itself breaks. No, the other part of the tooth itself breaks.
Tooth breaks. Okay,
Yeah,
fine. Tooth breaking. Okay, that has to be investigated a little bit more deeper. Debonding is a very small problem, doctor. There is some gap in the protocol that is being used. That is all. Because when I first started started bonded restorations, the first 10 cases that I did,
okay, sir.
okay, all of them debonded.
Okay.
All of them. That too within 3 months.
Okay, sir.
Okay, so the problem is not with the cement, it is not with the restoration, it is with the protocol that we are following.
Okay.
Get the protocol right, you will not have debonds. In fact, the bond is so strong that it is impossible to remove the restoration without actually cutting it and removing it. So if it is debonding, the problem is with the bonding protocol.
Okay.
The tooth fracturing is actually something that has to be investigated more. If you have, you can send me photographs on Instagram if possible of any pre-operative and post-operative photographs you have of cases that have failed like that, and I will try and see what the issue is. It is more of a biomechanical issue than a restorative issue. There has been some sort of biomechanical compromise to the tooth that has caused the tooth to flex and break.
Okay.
Okay. So that I cannot actually find, I cannot pinpoint what the reason is, but it has to be investigated because that will never happen with the partial bonded restoration. Tooth fracturing never happens. If the tooth is fractured, then whatever the prep design that has been done, or the the entrance restoration that has been done, there's a problem somewhere there. Okay.
Okay. So in my opinion, onlays doesn't work in root canal treated tooth. It works in vital tooth.
Okay.
But in root canal treated tooth, it doesn't work. But overlay works.
Now, what I'm doing are overlays. I don't do onlays. Onlays are basically, the problem with traditional onlay preps, right? Will have areas that have line angles and point angles. You have a proximal box. You have a full circumferential finish line that is supragingival.
Yes, sir.
Okay. Traditional onlay preps, as I said, that kind of retention form kind of preps are obsolete.
Yes.
Overlays work. Overlays are what you need to transition to. Onlays do not work. That is very clear. I was in the I misunderstood, as you were preparing overlays, and those are not working.
No. Overlays are working, sir, and onlays are not working.
Then it is a problem. Onlays, the tooth breaking is because there are areas of stress concentration. Stress gets concentrated there, and the tooth cracks. That is all.
Initially, I wanted to conserve the remaining part of the tooth structure. For example, distal part, I want to conserve. So if there is any mesial cavity. So I conserved distal part and I did onlay, but the distal part breaks.
Okay. I have done cases where I have, in endodontically treated teeth, I have just completely not prepared the distal part, first molars. Okay, where the access cavity is only like a small triangle on the mesial part of the tooth. Okay, in those cases, I have done restorations which have only restored the mesial part of the tooth. Okay, I have not had them fail. At least to this is anecdotal evidence at best, and different treatment protocols work differently in different people's hands. So, so for me, partial coverage in those cases, that kind of inlay I call them inlays. I don't call them overlays. Those kind of inlays work well. But being that that kind of preservative kind of work needs a little bit of experience, I think.
Yes, sir. Thank you. Thank
you. Okay, doctor. Yes, and there was another question by, after doing full restoration, even class 2 after RCT, can we go for overlay after sometime down the line? Dr. Nityanandam, can you please elaborate on your question, please? Can you come? Is Dr. Nityanandam available? He has asked, after doing full restoration, even class 2 after RCT, can we go for overlay after some time down the line? I hope I'm understanding his question properly. He is asking if post-endodontic restoration can actually be delayed. It's a risk. It's a risk because any endodontically treated tooth, especially one where the marginal ridge is missing, it is biomechanically compromised. So the chances of the tooth cracking are significant. So delaying it, that is one of the reasons why I, even if the patient is not able to afford the treatment, I give a 3D printed overlay, at least immediately. I wouldn't advise delaying. If the access cavity is only occlusal, yes, you can delay. But if the access cavity is one of the marginal ridges are missing, then it's a little bit of a risk to delay the restoration.
3D printed can be bonded or cemented, sir?
Yes, doctor. Solunga.
3D printed composite is bonded or cemented?
It is bonded. It is bonded, doctor.
Oh, same protocol.
No, you don't etch. You only air abrade.
Okay, sir.
Anyone else? Anyone else?
Sir, this is Yogita here.
Yes,
Uh,
doctor.
s- so that I wanted to ask it with an example. Say in case an RC is being done in relation to 3/6.
Okay.
But initio proximal of 3/6 has DC, and that's the reason why it is progressed and we are going in for an RC.
Okay.
Parallelly, the distal wall of 3/5 also has a cavity, but that doesn't require an RC. But doing a restoration doing a composite restoration might not take up the occlusal load. If that's going to be the case, can that be prepared and both the tooth can be given partial bonded restorations in that case? Then how do we go about with the marginal contacts and all those stuff?
Okay. See, since this is a hypothetical question, there are hypothetical scenarios that we have to consider. So the premolar, that is 3/5, has a distoproximal cavity, right? Am I
Yes,
understanding
sir.
that?
Yes, sir. Yes, sir.
Okay.
Distoproximal.
So what you could do is when you are preparing 3/6 for an overlay,
Okay.
you will get sufficient clearance to pass a burr from the side of the